We're good? We're live? Hi! Welcome back to Fertility Fact or Fiction, the show where we bring you all the latest and greatest, and Tarek right in the way.
Yeah, just noticed that.
Your whole head just went right in front of the camera.
Gets people excited.
So we had no show last week because I attempted to take a holiday, which was significantly interjected or interrupted by a family emergency. Everyone is well. Thank you to all of you for your very kind well wishes. We did have a little mishap out there and needed some emergency surgery, but it wasn't for me, just a family member, and that individual is doing well and recovering. So we managed to have a great holiday the rest of the time. I ate way too much and now I gotta work it all off in the next couple of weeks. So thank you for all your amazing well wishes and concern, much appreciated. I hope you guys had a good 2 weeks, and we're going to be back in action until the first week of August, and we'll probably do a live show from Michigan at that point. So until then, we'll be here every week again. Because I just literally got off a plane from Vancouver, I don't have a paper for you this week. So we're just going to dive right into questions. Hopefully we'll finish up by 9, and if you guys have anything specific you want me to touch on or talk about, I'm happy to do so. So we can go over anything you want to review and go over all the details. And I think there was one person that was going to ask a question on the private account, so you might be able to find it on there. And we'll look that up for you. So yeah, we have some questions lined up, but for those of you that want to ask your questions now, go ahead. If not, I can certainly talk about ovarian cysts and surgery. So one thing that can happen in the fertility world or gynecologic world is if you have an ovarian cyst, one of the risks of having a cyst is an ovarian torsion. That's when the ovary turns. And depending on how many times it turns, it can be extraordinarily painful, and it can cause ischemia to the ovary, meaning that your ovary is not receiving the blood and oxygen that it needs. And as a result, it can look quite black and ugly, dark, necrotic, kind of dead-like when you go in there to operate. It's usually caused when you have a cyst, and typically if the cyst is larger than 5 centimeters, you're at risk. If it's larger than 10 centimeters, you're at quite a bit of risk. So those are the ones where we need to operate in order to avoid the cyst from twisting on its blood supply. In the past, and I mean a long time ago, they used to just remove those ovaries because they would be concerned that the ovary would not recover. But the truth is that depending on how bad the torsion is, a lot of the ovaries do recover. And now how much is the function going to recover fully? We don't know. There haven't been studies of that, but there are what they call second look laparoscopies where people have gone back in afterwards to look at an ovary that they simply untwisted and maybe took out the cyst on. And then the ovaries look completely normal. So the procedure now is that we just untwist the ovaries and we leave them alone. And now in the fertility world, there's a lot of worry from fertility centers about surgery. A lot of fertility specialists have lost their surgical skills or just don't have the time to do surgery anymore and are super focused on just, the IVF grinder, as I like to call it, so everybody's getting IVF. So a lot of patients with endometriomas, dermoids, follicular cysts, persistent corpus luteum, are left with them and told they should not have surgery. Now there is a rationale behind that, and that is that there are many studies that show that if you remove cysts, in particular endometriomas, from the ovary will transiently weaken. So you can diminish your ovarian reserve by operating on the ovary. So personally, there are 2 reasons I don't really follow that. Number one, there are good studies that have shown that the cyst itself diminishes the ovarian reserve. So it's not like the surgery is making it worse. Leaving the cyst there makes it worse already. So it's not like it's helpful if you just leave it alone. Number 2, in some cases, especially with an endometrioma or a dermoid, they only get bigger. They don't go away by themselves. And so it's only going to damage the ovary more, mean more tissue trauma when you finally do need to operate, which you likely will, and more pain and more inflammation. plus the whole endo and infertility complex. I mean, obviously, it's not great to have endometriosis when you're struggling with infertility. And then the other reason is that we know for sure that the change in the AMH and the antral follicle count is transient. So after 6 months or a year, it does come back to normal, and there's no difference between the group that got surgery and didn't have surgery. So it's a transient effect. So I don't necessarily tell my patients they all need surgery because I don't believe in cookie cutter medicine, but I do believe that patients should be offered a intelligent discussion of the risks and the benefits, and in some cases they should be offered surgery first. Now, it's controversial if your ovary has twisted whether or not you should or should not have surgery. There's absolutely no evidence on it whatsoever, but if the ovary is black because it's been ischemic for a while from the torsion, it can be very fragile tissue and therefore difficult to operate on. If it's not a really tight torsion, it's a more gentle torsion, you can get away with it without any damage to the ovarian tissue, in which case you probably should do the cystectomy. If you've torted enough times, you need to actually sew the ovary to either a ligament or the sidewall in order to prevent it from being able to twist again. That's kind of the story on ovarian torsion. Typically presents with sudden onset of very, very excruciating, agonizing pain, vomiting. The pain tends to come and go, it waxes and wanes, and it's very, very uncomfortable. So those women actually need to have attention paid to them. There is no way to diagnose torsion without actually seeing it. So we do use Doppler ultrasound where you can see blood flow, and certainly if you see no venous or arterial flow, mainly arterial, going to the ovary, you get concerned. But the presence of arterial flow does not rule out a torsion, and that's been shown in many studies. So if you have a big cyst, you've got that waxing and waning pain, you're puking, the pain is quite significant and it's terrible, you have to at least consider the value of having a laparoscopy so they can see and unflip the ovary. If you don't unflip the ovary long term, the ovary will die, and you can't have dead tissue inside you because it becomes necrotic, and that's a risk for infection. So we do need to end up removing some of those ovaries if it's been too long that it's been in there. So that's the story on ovarian torsion. Hopefully people have had some time to ask some questions. If you have questions about cysts or surgery regarding cysts, or even about any of the torsion impact, I'm happy to answer those as well. But we're just going to take your questions tonight. And I'm sorry I'm kind of grizzled, but I didn't have time to shave. Yeah, fire away.
Ready?
Yeah, I'm ready.
Okay. After 2 failed transfers, 1 artificial, 1 modified natural, doctor recommended ERA. Would you recommend estrogen PIO ERA or modified natural ERA? Pros and cons of each.
You should never do ERA. ERA has been proven in so many studies, I've actually lost track now, to not be beneficial at all. There is absolutely not a single study out there that demonstrates a benefit to doing the ERA. Their own study did not show a benefit. So there is no value to doing an ERA. If you're having multiple failed transfers, you should actually either look at the quality of the embryos, or look at the quality of your lining, or consider evaluating your immune system, but do not bother doing an ERA test. It is absolutely useless. The easiest way to know that the ERA is useless is they claim that there's this 6-hour window. In fact, in some places they say 3 hours. So 3 to 6 hour window of opportunity to, or of implantation, within which you have to put in the embryo or it won't work or won't give you the same success. So there are lots of studies that show that there's actually no difference in success rates if you put in a day 5 embryo after 5 days or 6 days of progesterone. It makes no difference. And we do that here all the time, because if the lining isn't compressed enough, they haven't gotten enough progesterone, we go an extra day with the progesterone and we don't see a difference in the outcomes. So that idea that there's only 3 to 6 hours is total nonsense. It just absolutely is not true. I was a hardcore devoted ERA fan. I adopted it very early on. I kind of fell for it hook, line, and sinker. It made a lot of sense biologically to me, and the reality is it actually doesn't work. Why it doesn't work, I don't know. I wish I did, but it actually doesn't work. So save your money. Do not do an ERA. It's totally useless. You're better off figuring out what's wrong without doing an ERA and then going ahead with that. And endo can be a cause of failure. So surgery is one of the things we consider when our patients have had more than 1 or 2 failures.
What percentage of embryos would be euploid at 31? How many live births would you expect with 4 embryos?
So a third of them will be abnormal. 25 to 30% will be abnormal at 31. So if you have 4 embryos, you would think that probably 1 is abnormal and 3 are normal. There's a good study from Richard Scott's group that demonstrates that if you have 3 euploid embryos, genetically normal embryos, it gives you a 95.2% chance of 1 live birth. 84% would be 2 if you assume there's a 50% per embryo implantation rate. So you should be able to achieve somewhere between 1 to 2 live births with 3 genetically normal embryos.
Do you see a difference in live birth rates between an embryo graded 4 AA and an embryo graded 4 BB?
Yes, there is a subtle difference. And there's a study we reviewed on the show probably 2 months ago, which did demonstrate that even subtle changes in morphology does have an impact on the outcome. So that is something that plays a role. It's not a huge role. It's really below BB where we start seeing drop off. So there's not a big difference between a BB and an AA, but there is some difference between a BB and an AA. Not huge. You'll still get very, very good success rates with both.
Are your patients able to travel outside of the country for a mini vacation and continue receiving treatment upon return?
If you are going outside of Canada for a non-essential purpose, to the best of my knowledge, Ontario is still locking people down when they come back in a quarantine if it's a non-essential visit outside. However, I think it's changing very quickly, and what you say is essential is totally up to you. So if you're double vaccinated and you've left Ontario and you're coming back in, as long as you test negative for COVID, they're not making you quarantine anymore. But that's assuming you're going over there for a non-essential purpose. For an essential purpose. If you're going for a non-essential purpose, I don't know what they'll say to you when you come back, but I think they're opening it more and more right now.
Had a recent miscarriage chemical at week 5 with a PGT tested 6-day embryo. FET took place after 5 days of progesterone exposure. Do you know what might have caused this? Progesterone exposure too short?
Could be. So the study we reviewed, which on our YouTube channel says 6 or 7 days of progesterone, which one is better? So it's actually 5 days or 6 days of progesterone. We got to change the title on that one. So if you transfer on day 6 with a day 6 embryo, the miscarriage rates are higher than if you transfer after 6 completed days of progesterone, which is day 7. So they did demonstrate a higher rate of miscarriage. So with day 6 embryos, we go the extra day of progesterone. And that's another reason that ERA test is useless. So yeah, we focus on the stage of the embryo and then select our progesterone dosing based on that. Keep in mind, a genetically normal embryo could miscarry for multiple reasons. It could be genetically normal, but still be single gene genetically defective. So for example, if you have multiple single genes that are not normal, it may impair the ability of the embryo to develop. You could have a very energy inefficient embryo. That can also cause implantation failures or pregnancy losses. It could be a sperm DNA fragmentation problem. That's associated with a huge increase in the risk of miscarriage. Dr. Serena Shen posted yesterday or this morning, and I did a follow-up post talking about smoking and the impact on maternal miscarriage. Even if the guy is smoking, the miscarriage rates for the embryos are much higher because the sperm DNA fragmentation is significant. So, and we've been telling you guys that for the whole time we've done this show. So, that's really critical. It could be your immune system. It might not have anything to do with the embryo whatsoever. If you have infections in your uterus or your immune system is overactive, those can impact things as well. It could be the shape of your uterus, polyps, fibroids, again, having nothing to do with an embryo. So we have kind of a checklist of things we go through when we have failures, and I speak to my patients about each and every one of those. We figure out what they want additional testing and or treatment for, and then we move forward from there. Some patients don't want and or need anything, whereas other patients want everything tested before they go for another transfer. So you have to judge by the patient and how many embryos they have. Obviously, if you have 10 embryos hanging around and you failed one, that could have been just a bad embryo, and there's no reason not to try again without a whole lot of expense or fancy treatments or tests. If you only have 2 embryos or 3 embryos, you may want to do everything before you use another one because you've got a limited batch. So it depends on each patient. And again, never go somewhere where it's cookie cutter medicine. I've had a number of people messaging me during my vacation saying, I'm going to this center and my IVF can only be done at this one time. That's never going to work. There's got to be some flexibility. You may need to wait a month, but then they can accommodate you. But there should never be a time where you can't get what you need because they're saying we just don't do that. That's never going to work out, guys. You have to have a flexible program or else you're not getting good care.
What would you recommend for someone with a cyst of 3 centimeters?
Well, it depends on what kind of cyst. So if it's just a follicular cyst, 3 centimeters, I'd probably just watch it. If it's a persistent cyst that hasn't gone away, it's affecting your hormones, it's a dermoid, it's an endometrioma, those ones I would remove. If you get a good surgeon who knows what to do, it's not a problem. So if this is your ovary, it's like a little circle or a sphere. If you make a single linear cut on the surface of the ovary, and then you kind of peel the ovary open, scoop out the cyst from the inside, and then leave the ovary alone, you won't do any damage to the ovary. You're only getting those eggs that are in that one little line where you're burning. That's really critical because it minimizes the amount of tissue trauma and allows you to get the cyst out without any damage. The other problem a lot of people get into is that many centers are not trained in fertility preservation techniques. And when they open up the ovary and remove the cyst, there's bleeding. I mean, it's an organ. It's got a very rich blood supply. It's directly connected to your aorta. And so, they will have bleeding from the base of where the cyst is. So 99% of the time, if you leave the ovary alone and do nothing to it, just put in some stuff that helps with getting it to stop bleeding and just wait 10 minutes, the ovary will stop bleeding. What a lot of people do is they take an instrument called bipolar cautery, which just allows the current to flow through the instrument, and they start burning all the parts of the ovary that are bleeding. Well, if you burn the ovary at its blood supply, which is where the majority of them bleed from, you've now damaged the blood supply to the ovary. That obviously, on top of the thermal damage and the cooking of all the eggs that are there literally, is going to traumatize the ovary and have very significantly negative impact. So finding someone who is not just a good surgeon, but also knows how to preserve your fertility is critical. Unfortunately, there are actually very, very few of us around because you really need a fertility specialist that does surgery. There are only a handful of us that still do that. Most surgeons just want to make it quick because they've got a lineup of other cases. Even minimally invasive specialists don't always do the right thing. I've seen videos brought to me from other countries or other procedures where they went crazy and barbecued the tube and damaged the ovary and all sorts of things, and that was considered, experts. Those are not experts. They don't know what they're doing. So you need to find someone who knows how to preserve the ovary when they're doing ovarian surgery. Typically, that's a fertility specialist that has extensive minimally invasive surgery training and also is aware of all the impact that the cystectomy can have on the ovary.
What are the chances of conceiving naturally each month versus IUI versus IVF?
So it depends on what's wrong. In a healthy, normal couple, it's 10 to 15% per month. In an infertile couple, it depends on what's wrong. I mean, If you have severe male factor, it can be less than 1%. If you have polycystic ovarian syndrome and you're not ovulating, it's 0. So I can't answer that without knowing what's wrong. In general, I can answer the IUI part. So if you're using just pills, for example, let's say you have PCOS and you're just taking letrozole, over 6 months of use, it's 27.5% live birth. If you're doing letrozole with insemination, you're bumping that up to about 10 to 15% per month. Some people would argue a little bit lower, 8 to 15%, but somewhere in that range. If you're doing it with shots, you got to be careful. But most studies will support about a 20% chance per month up to 25. So it depends on what we're talking about. If you've got bad endo, cut all those numbers in half. If you've got severe male factor, cut them even more. So it depends on what the diagnosis is.
Should you continue to work out post IUI? My normal routine is Monday to Friday, 5 a.m., 1 hour CrossFit.
Wow. Okay, so first of all, you need to come hang out with me and Tarek because we're both out of shape. So that's too much. CrossFit's high intensity, and waking yourself up at 5 in the morning is probably not ideal. So I tone that down a little. If you want to do some light aerobics, some light weights, that's fine. But CrossFit, HIIT training, spin class, that stuff, that's too hardcore after an IUI. Remember that when you're doing that kind of thing, your blood flow is going to 2 places. 1, all the muscles you're using, and 2, your skin to help cool you off. Anytime you pull blood flow away from the uterus, that's not an ideal circumstance. So reasonable amount of exercise is good, but nothing too strenuous.
Hi, Dr. Victory. I have been diagnosed with unexplained.
Okay.
I have a high TPO, about AB greater than 1,000.
Wow.
I'm wondering if this could be a thyroid or killer cell issues. Any advice on diagnosis? Thank you.
Well, if you have thyroid antibodies, you definitely have thyroid disease of one sort or another. If your TSH is over 2.5, you should be on some type of thyroid medication to drive your TSH down as low as possible without getting your T4 to be excessive. You should be taking selenium because selenium can reduce those antibodies. And yes, you may need an immune protocol. So those are the patients. Sometimes we use steroids, intralipids, hydroxychloroquine. There's a bunch of different things you can use, all of which will help contribute to reducing the inflammation. That's not necessarily going to solve the infertility. So you need a thorough evaluation, including surgery, to rule out all possible causes of unexplained. If you're unexplained, we do this every show, so I'll do it again. There's only 4 things that work for unexplained infertility. Surgery to rule out things like endo, adhesion, scarring, that kind of thing. Pills with insemination, shots with insemination, and IVF. Nothing else works. It's only those 4. So a lot of people get, letrozole or Clomid and they're told to go try it. That's useless. It doesn't change the outcomes at all.
My doctor said they recommend waiting a month between FET. Why would that be?
Just to give your body a chance to go back to normal after you've taken a bunch of hormones. It actually doesn't make any difference, and they've studied that before. So whether you wait a month or you don't, it doesn't change the outcome.
I just want to say thank you so much for doing these questions and answer sessions. It helps so many people.
Oh, well, thank you for being there to ask and for watching. We appreciate that. We love doing this show. It's fun for us. So we're always trying to make it bigger and better. But yeah, I know people love the question phase. It's actually funny if you watch a graph of the audience for this show. When I present a topic, we get a reasonable number of people watching. And then there's a huge spike after about 20 minutes when most people know that I'm just going to live questions because everybody just wants to get their questions answered. I think they're less interested in listening to the topics. So tonight I figured I'd just go jump right into the questions.
What TSH do you like the IVF patient to be under before transfer? And is this for all patients or just patients with a history of thyroid issues?
No, it should be for all patients.
And the second part of the question was, how common is it percentage-wise for an IVF patient to need thyroid medication?
Okay, so Endocrine Society has guidelines for this. So they say under 3 for your TSH in the first trimester, 2.5 for second and third. We actually just aim for 2.5 for everybody. But if you're borderline, like you're at 2.6, at 2.7, at 2.5, I won't give you anything. Everybody should be that. It's not just any specific patient. And as far as what percentage, well, 10 to 15% of women have thyroid disease. I'd say probably somewhere around 20, 25% of our patients need thyroid supplementation. I'm guessing, I've never looked at that specifically, but that's probably a reasonable estimate. Yeah.
How long after retrieval and fresh transfer can I work out and not risk ovarian torsion?
Oh, probably a minimum of about 2. Well, it depends on how many eggs you made. So if your ovaries were PCO and you made tons of eggs, most likely a month, 6 weeks. If they were smaller, you only made a couple of eggs, you may not need to wait at all. I'd say minimum kind of 2 weeks, just to not stir up any trouble with bleeding, hemorrhage, that kind of thing. If you had a big retrieval, like they took 50 eggs out of you, you're an egg donor, yeah, a month and a half to make sure the ovary shrinks down again.
For unexplained, would you recommend taking the hidden C test with the SPI test for men?
Yes. I don't think there's any direct evidence. Well, in fact, let me rephrase that. There is no direct evidence that either of those tests are useful in the diagnosis of unexplained infertility. However, we do see a lot of patients with the hidden C test that we treat and then they are able to conceive and more importantly, not just conceive, but stay pregnant because it's probably more associated with pregnancy loss than it is with getting pregnant. The SPI test, which is a sperm infection test, there's virtually no evidence for anything in that regard. I'm not saying it's not a valid test. I've actually done it a couple of times and I'm kind of a believer, but there is no evidence. So we don't know if that's helpful or not. You'll get a lot more from a sperm DNA fragmentation assay than you would from the SPI test.
What causes an ectopic pregnancy? Is it chromosome related?
No, it's definitely not chromosome related. So number one cause of an ectopic pregnancy is previous infection in your fallopian tube. So that's chlamydia, gonorrhea, PID. Number two, any kind of damage to the fallopian tube from previous surgery. So a previous ectopic, previous tubal surgery, that kind of thing. Smoking is a huge risk factor. Drug use can be a risk factor. Any kind of previous infection or inflammation, your appendix burst, infection spread through your pelvis. Endometriosis, if you have an IUD in situ, there's a 70% chance you'll have an ectopic pregnancy. So there's a lot of different factors which can contribute, but number one is, have you ever had chlamydia or gonorrhea? Has absolutely nothing to do with chromosomes. Zero.
What happens if you make embryos, but then find out you need a surrogate, but you didn't do the communicable disease testing beforehand? Can you still use the embryos or surrogate?
In Canada, yes. I don't know what the laws are in the US yet, although I will soon. Yeah, in Canada you can because there is no regulation surrounding embryos. However, we would not be willing to transfer unless we knew that at the time that they were made, the egg source and the sperm source had no sexually transmitted or communicable diseases. There is no way in North America, or probably even in Europe, that you made it through an IVF cycle without a communicable disease test. Because they need to know at the IVF center if the handling of the tissues could be a risk for the people handling it. So there's no way you did that. If you did, something bizarre has happened. And you could get tested now. If you test negative now, it means you had to be negative then. If you tested positive for something now, we don't know if you were positive then, but we would not take any chances and would have to assume you were.
What happens if you make embryos, but then find, oh, sorry.
Same one?
Does having low ferritin 18 cause any fertility issues? It's an issue. I have FET in a month. Can I get iron up to a good level on time?
You can probably get your iron up to a reasonable level on time. Make sure you're taking a glycosylated iron, so Ferromax, Triferex, Eurofer, Palifer. If I'm missing one, forgive me. Any of those is fine. Or you could do iron infusions if you're somewhere where they allow that. Yeah, there is a study that demonstrates that if your iron level is low, your fertility is compromised. So we do check it on our patients now.
What test should be performed if one had a miscarriage with a PGT-tested embryo? Dealing with male infertility, no known issues on my end. BMI normal, took baby aspirin during the process.
Saline infusion, sonohystogram, complete hormone profile, especially your thyroid, sperm DNA fragmentation test, possibly surgery to rule out endo, hidden C testing from Fertilicist. They don't call it that now. They call it something different. The menstrual blood test, I think they now call it. Immune system testing is reasonable as well. Or to be honest with you, no testing whatsoever. So it's not unreasonable to actually do nothing and simply transfer another embryo. Keep in mind that in one of the largest studies of PGT done with Schoolcraft out of Colorado, even with a PGT tested embryo, they only had a 62 or 63% success rate. So there are going to be genetically normal embryos that don't implant. So using that data, most people use a number of 50%, 60% in that range. It's not unreasonable to just simply do another transfer. You don't have to jump into a lot of testing. Again, it very much depends on how many embryos you have. If you've got 10 embryos, I don't think you need a lot of testing. I would just try again. If you've got 2, yeah, I would want everything done so that we don't, waste an embryo for you.
RPLX2, one chemical, no explanation. Protocol includes intralipids, SCIG, and prednisone. Had lots of side effects with prednisone last time. How much benefit does the prednisone offer?
So if you look at the research, it's very controversial. There are lots of studies that say it's useless and lots of studies that say it's beneficial. So that's a hard one to answer. We do use it. You shouldn't be getting side effects at the low doses we use. So usually we just use 25 milligrams. If you're using more than 25 milligrams, that's probably a bit much. And you can turn it down if you need to. So sometimes we just use 10. At that level, most people have no side effects. But let us know what level you're on and speak to your doctor. If you're on subcutaneous IG, you're either my patient or Fred's patient, because I don't think a lot of people are using it otherwise. So let us know who you're working with. Certainly if it's us, we can turn down your dose. If it's someone else, talk to your doctor.
When it comes to endometriosis, is there a better success rate with fresh transfer versus frozen transfer or vice versa?
Oh, yeah, 100 million%. Think of the biology here, folks. You should never get a fresh transfer with endometriosis. It makes absolutely no biological sense whatsoever. So what feeds endo? Estrogen. When is your estrogen level at its highest? When you've done a fresh IVF cycle. When would your endo be in full effect? When you're doing a fresh IVF cycle. When should you not transfer? When your endo is in full effect. So that's like simple A plus B equals C. Like you've got endo, you've got the thing that feeds the endo, don't do a transfer. I mean, that's like a total no-brainer. I'm shocked when I get told that people with endo did a fresh transfer. The sole exception is for people doing natural IVF cycles where their estrogen level is not getting any higher than it does in a normal cycle, or at least it shouldn't get much higher. Okay, that's not unreasonable, but in every other scenario, if you've gone through ovarian stimulation, your estrogen levels are supraphysiologic, meaning above the normal cutoff. For God's sakes, do not do a fresh transfer. It makes no sense. And there is a good study we reviewed that showed that for unexplained infertility patients, letrozole and Lupron for 3 months improved the chances of success. The rationale for the change in success was that those patients had endo. Now, there isn't direct proof of that, but it makes sense. And if you look at the stats and the number of patients that would in the general population have endo, it actually fits in really nicely. So in my opinion, humble opinion only, there's no scientific evidence for this, it does not make sense to be doing fresh transfers. You should always have frozen and take the 3 months in between to be on something that suppresses the endo.
Could Claritin be an option with any benefit?
The studies on antihistamines and infertility are not great. They're few and far between, and none of them were super clear about showing a benefit, but there are protocols out there that use it. There's one physician in the US in particular that uses it a lot. That physician, I was just telling another reader or viewer who messaged me privately that that physician just likes to give people options all the time because they just keep bringing people back for more and more treatments. I'm not a huge fan of that approach. I believe in diagnosing what's wrong, fixing it, and then addressing it. With treatments that work, I don't believe in, hey, let's try this time, and if that doesn't work, let's try that next time, and then going on and on. I kind of like to review every single option you have, go through them all with you, and then let you make an informed decision. So antihistamines may be beneficial. I have used them. I didn't think it worked, but if you want to try them, they're probably harmless. Aside from the fact that you might get hyper, there's no side effects from taking Claritin. Most people get sleepy. Some people get hyper.
Had a recent miscarriage.
Sorry.
My HCG jumps up and down even after having my period. Anything I can do to help the HCG go back to a normal naturally?
Your HCG should not be going up and down unless it's a very low level. So if you're like 5, 7, 10, that's probably nothing to be concerned about. But if you're in the hundreds or 50, 60, 70, 100 and it's going up and down, either there's tissue in you or you have an abnormal version of a pregnancy called gestational trophoblastic neoplasia, and that can be serious, so you need immediate investigation.
To what degree is loss of libido normal when struggling with IVF and infertility? What would you recommend to naturally increase female libido?
Great question. I haven't gotten around to doing the show on sex. We got to do that. So maybe in the next week or so, we'll do one on sex. Week or two. Okay, so it's very normal. The strain and the stress of fertility or infertility frequently impacts your sex drive. So it's very normal to have decreased sex drive. If you're a guy, or for that matter, a woman, it's actually very difficult to treat low libido while trying to conceive, because the only thing that actually works is to increase your testosterone. And you can't do that in a woman easily, at least, depending on where she is in the cycle, because it can take a female fetus and masculinize it. So, for example, if you're getting ready for an FET, you can't do that. If you're doing IVF, we use testosterone for priming, so that's reasonable and would help you a little bit with your sex drive. For a guy, if they're taking testosterone like a lot of our bodybuilders, that just shuts off your sperm production, so you can't do that at all. So psychological stuff is helpful. Communication is number one with your sex life. So telling your partner what you like, what you don't like, telling them how you feel. A lot of women are emotionally linked for their sex drive. Not all women, but many women are. So if you read studies on this or books on this, they'll talk about the emotional link, whereas guys are tend to be less emotionally linked. So for a woman, it can be something simple like kind word or intimacy without the sex first, just cuddling or being close to one another, or picking your socks up off the floor. So it can be something really subtle. For men, it is often an attraction thing where they want to see that their partner is interested in them or that they're putting an effort into it. So it differs from couple to couple and from person to person, of course. Everybody's different, so there's not a one-size-fits-all approach for this, but communication for everybody is universally helpful because it will improve things for sure.
I'm on a medicated FET after several months of Lupron suppression. on a 10-day of using one estrase a day, 2 milligrams. My lining is 8.04 today, and E2 is 83. Should I increase E2 to 1.5 or 2 pills a day?
There was that study we just reviewed that said you should get it over 100. So I'd probably increase it to 1.5, but it depends on whether you're taking your estrogen vaginally or orally. So be careful because you could overshoot the mark as well. So yeah, I'd maybe tweak that just a little tiny bit, but you're probably close enough. It's not a real issue.
Do you ever do a natural FET or do you usually do medicated? If yes to medicated, what is a typical protocol?
We should just do a post with our protocol. Okay, so we go through our protocol every show now, and I don't hide our protocol from anybody. You're welcome to it if it's going to help you. Okay, so we do mostly medicated. We do some natural protocols. If I have someone with immune issues, we'll sometimes do a natural protocol. Estrogen is not great, so we try and eliminate that. Okay, so day 21 Lupron, cycle day 3 letrozole, antibiotics. We take the letrozole for 5 days, the antibiotics for 5 days. Then we put you on a probiotic, and in the meantime, you're on vitamin D, melatonin, and aspirin the whole time. Plus iron if your iron is low. We monitor your lining thickness. We wait until it's over 8-9 millimeters. When it's at that stage, we initiate your progesterone. We use progesterone vaginally and in oil. The vaginal depends on which one you're using, but they're standard dosing. Progesterone in oil, we start with 50 milligrams. 3 days into it, we bring you back. We check to make sure that the lining has compressed a little bit, so it's smaller than it was, which means the progesterone is working. We check to make sure your progesterone level is normal, so we want it between 40 and 100, not higher, not lower, and we make sure that your uterus isn't contracting too much. So as long as all of that stuff's in place, we do your embryo transfer for a 5-day embryo after 5 days of estrogen is completed, progesterone is completed, and for a day 6 embryo after 6 days of progesterone is completed. Typically the next day we bring you back and we'll recheck your progesterone level to make sure it's staying in the right range, and we do adjust it if necessary based on wherever you're at.
I heard you recommend tests by Fertility. What does their menstrual blood test microbiome tell you? More specifically, what is the antibiotic susceptibility test? Took the test, but no consults.
Okay, so the test tells you if they have found the DNA, well, technically the RNA, but eventually, or by corollary, the DNA of bacteria and viruses in the menstrual blood itself, which by extension should suggest that it's in your uterus. If you have infections in your uterus that don't belong there, there are many studies that now support that decreases your chances of success naturally, and especially with fertility treatment. So the vaginal microbiome, as they call it, and the uterine microbiome are very important to your success rates. Depending on which bacteria you have or don't have, because some of them you're supposed to, like lactobacillus, other ones you're not supposed to, the antibiotic and treatment profiles are different. That's why we put all our patients on an antibiotic and then on a probiotic, because we want to kill the bad ones, fluff it up with the good ones. When you come back with fertility testing that's positive, we frequently need more than one antibiotic, and you need to be on that stuff for a long time, like a month. So it's not the kind of thing you try and do on your own. You need a consult because you're going to need prescribed antibiotics anyways.
What is the success rate of an early blast, such as a 1-2 expansion, if they were frozen on day 5?
Depends on whether it continues to expand. It is lower than if it's a 4 or a 5. So we actually have a study on that, and I think a show on that. I think if I remember that graph correctly, it actually did have the lower grades. So when you freeze it, a 4 or a 5 is best, and when you thaw it, a 5 is best. 1 and a 2 is definitely going to have a lower success rate. I don't remember the numbers off the top of my head, but you are going to see a decrease in success. But go back, I don't remember. Was that like 2.5, 3 months ago? It's probably about 2.5, 3 months ago. It'll be on our YouTube channel. So we'll go back and have a look at that. But it is there. What was that one called? I think it was the morphological scoring with a frozen embryo transfer. So have a look at that one.
What factors impact whether or not a fertilized egg makes it to blastocyst?
Oh God, everything. The skill of the embryologist, the quality of the sperm in the egg, sperm DNA fragmentation, the lab, the equipment that they use, how quickly they did everything, how slowly they did everything, which media it goes into, your health history. Are you a smoker, drinker, drug user? Is your partner? Are you morbidly obese? Is your partner? Oh my God, I could sit here for hours just going on and on and on. There are so many factors. And sometimes literally there's no reason for why we end up with a good or a bad embryo. So there's a lot of different factors that can go into it. A lot of it has to do with health. Huge amount of it has to do with age. Huge amount of it has to do with your social habits, smoking, drinking, drug use. And probably the biggest part of it, aside from all of those things, is the lab. I mean, you get a great embryologist, you're more likely to have great embryos. You get a crappy embryologist, you give them the best tissue in the world, you're not going to get a good outcome.
What indicators do you look for when diagnosis male factor?
I'm not sure I understand that question. What indicators do I look for with a diagnosis?
Male factor.
Oh, when diagnosing male factor? Well, the sperm analysis. So how many sperm are there? Well, what's the volume? What's the thickness or viscosity? What's the count? How many of them move? How fast do they move? How many are normal or abnormal? So those are the 6 standard parts of any sperm analysis. We frequently now do sperm DNA fragmentation as well, which also is useful in diagnosing problems. So we do recommend that for patients where they're struggling. And then, of course, the health history. So is he a smoker? Is he a drinker? Is he a drug user? How much of those is he doing? Does he take vitamins? Does he not take vitamins? Are his testicles hot? Is he in a job where he's sitting all the time like a truck driver? Does he do bicycling? Those kinds of things. Anything that puts pressure against the testicles is not good. Hot tubs, heat, tight underwear, laptops that are actually on your lap, any of those are kind of detrimental. So there are some lifestyle work-related things that can contribute. Weight is huge in guys, so is he obese? Does he exercise regularly? All of those are things we look for.
When to do a pregnancy test after IUI?
2 weeks. That's easy.
All right. What TSH do you like the IVF patient to be under before transfer? And is this for all patients or just patients with a history of thyroid issues?
Yeah, we answered that earlier. So Endocrine Society says 3 in the first trimester, 2.5 in the second trimester. We try and just get everybody close to 2.5. Now, if they're just getting pregnant and they come in with a 2.7, I don't normally treat those people. But if it's 3, 3.2, 4, anything in the 4s, even in the mid to high 3s, we treat all of those patients. And you want to get them below 2.5.
If you have a partial or full placental abruption, what's the chances of it happening again?
It depends on why you abrupted. So if it's because of a fibroid or something modifiable like smoking, cocaine use, high blood pressure, those are all manageable. You can remove fibroids, you can stop smoking using cocaine, you can control blood pressure. So those can drastically be altered. If it's an unexplained partial or complete placental abruption, which is rare, that would be bizarre in the absence of something being wrong. So I would want a very thorough evaluation, especially for things like lupus, autoimmune diseases. But if you're truly, truly unexplained, you had a full abruption, that's probably got a reasonable chance of happening again. I don't know that I could quote you a specific percentage, but way higher than we would necessarily be comfortable with.
What happens if you make embryos but then find out you need a surrogate but you didn't do? Oh, what's going on? I did that one too.
Yeah.
Uh,
Maybe they asked early and asked again.
yeah, it looks like it. Okay, here we go.
Yeah.
A new one.
Okay.
What causes pregnancy in unknown location? Never had an STD nor issues with fallopian tubes.
So I ran through the ectopic list earlier. Typically, it's infection. Sometimes you don't know if you've had an STD. 40% of chlamydia infections are silent. Smoking is a huge one. Bad luck. Previous surgery, previous scarring. If you've had a DNC, it could have done damage. If you've had a cesarean section, it can end up in the scar. There's all sorts of different reasons. Previous appendix, like appendicitis, that kind of thing.
I was told taking prenatal vitamins would help prepare the body to be pregnant. However, I also heard taking prenatal vitamins can negatively impact your body after long use. I am confused.
You're not confused. Whoever told you that they can negatively impact your body is an idiot. So don't listen to whoever said that. There is no detrimental side effect to taking fertility vitamins or prenatal vitamins for a prolonged period of time. It's totally healthy. Keep in mind that the vast majority of people are vitamin deficient in not just one, but innumerable vitamins and supplements. So taking it just actually brings you close, not even always fully, up to where you're supposed to be. So it's not going to be detrimental for you. Don't listen to people that say stuff like that. That's what we're here for.
At 43, AMH of 2.37 nanograms per mil.
Oh.
How many eggs on average can be retrieved? I've seen the embryo math video, but seeing if this AMH will yield more.
Yeah,
Thanks.
you'll yield more. That's a pretty decent AMH, so I would say at least 10 or 12 would be reasonable. Granted, everybody's different, but somewhere between 8 to 12 eggs for an AMH in that range would be very, very reasonable. The rest of the embryo math, though, you've still got to follow at that age. So your genetic abnormal rate will still be somewhere around 75%, maybe even higher, 80%. So expect that if you get, let's say, 10 eggs, that they can fertilize 9 or 10 if you go to a good center and they use ICSI. So from that, about 50 to 60% will become blastocysts. So let's say you end up with 6. Let's go with the hopeful numbers. So you end up with 6 embryos that are available. If 80% are abnormal, it's entirely possible you end up with no genetically normal embryos. So you would actually need to go through 2 cycles to have enough embryos to hopefully guarantee, and there's no guarantees, but hopefully guarantee that at least one of them is genetically normal, ideally 2. If you get 1, you're looking again at that 50 to 60% chance of a live birth.
Do clinics sometimes purposely give mediocre care just so they can make money on continuous IVF cycles?
I don't know what other clinics do. I can tell you we don't do that. I suspect other places do. Where, who, I would never get into that, obviously, but I think there are lots of places that feel that if a patient doesn't succeed, it's not a big deal. They can try again. I don't necessarily think anyone wants to give mediocre care, but I do believe there can be that mindset that, well, it might take you more than one try. My mindset is I failed you if it takes more than one try, so I don't want you to be here more than once, because to me that means, you know, I failed you somehow. And not that I didn't do everything I could, it just means that I didn't end up getting to where I wanted, which is I want everybody to succeed on first try. There's no question that a lot of centers build huge IVF programs by just churning people through over and over again. That's just not the model I want to be part of. I want to optimize everything for each patient so we're successful as close to first try as possible, ideally on first try.
We are starting IVF with you next month. I have PCOS
Okay.
and very irregular periods.
Not a problem.
I am currently day 7 of my cycle
Okay.
and was not told to call on my day 1 this cycle to start with birth control. Does this change anything, or do I wait until my next cycle starts?
If your cycle's really irregular, we would normally put you on the birth control pill, which the girls are probably planning. So why don't you reach out to Sarah? So it's Sarah at drvictory.com. That's Sarah with an H. And just email her and say, hey, what's up? And if you, for any reason, don't get a response within the next day or two, just DM me and I'll take care of it.
Unexplained. Failed 5 FET transfers.
Oh.
Doc is suggesting I try progesterone and oil shots for the next transfer. What are your thoughts on that option?
So if you failed 5 frozen embryo transfers, progesterone and oil is not likely going to be the solution. Having said that, everybody should be doing progesterone and oil because they've proven now that that's better than just vaginal progesterone. But you need full workup. If your doctor is telling you that the only thing you need to do is progesterone and oil, they don't know what they're doing. Sorry. So you need more than just that. You need a thorough evaluation, hysteroscopy, laparoscopy, the fertility testing, immunological evaluation, sperm DNA fragmentation testing, probably PGTA of your embryos. Like, that's a lot of embryos to fail. Something must be wrong, and oftentimes you can figure out what it is by doing enough tests. Are the tests cheap? No, they're super expensive, and I apologize for that. Even though we don't actually charge for any of those tests, we just charge whatever the companies do. But they are necessary. So you need to have all of that evaluated. Don't just jump into another embryo transfer. It's going to fail again. You're not going to succeed by just adding in PIO. That will never fix something like what you just described.
My doctor said some of my blastocysts had abnormalities. I didn't do a PGT. What kind of abnormalities could she be referring to?
Dark center, granular cytoplasm, thickened zona or shell. There's a lot of different things they could have. Large vacuoles. They can be an abnormal shape or asymmetric. There's many different things, so I can't really just like pinpoint one.
Husband has 75 MIL sperm, motility normal, however morphology 1%. Doc says okay because of ICSI, ABS, IVF. Is this true?
Yeah, that's true. I mean, they got to have a good program which finds that 1%, but if he's got 75 million sperm per milliliter, let's say he only has 1 milliliter, which I'm sure he has more, but if he only has one, you've got 75 million sperm. 1% is 750,000. So they've got 750,000 sperm to find. That's not going to be that difficult. They can find the 10 or 12 they need out of 750,000. So as long as you get a center that is diligent and good, and they spend the time to find the good sperm, you won't have a problem.
My estradiol is 6,300 pg per mil. After finishing 9 days of stims, I will trigger with overdrill tonight for retrieval Wednesday. What do you think? Am I off to a good start for success? 38 years old, unexplained.
Double trigger, so you should be getting Lupron and HCG. And we don't use Ovidrel for triggers. We use HCG. Not that there's anything wrong with Ovidrel, we just don't use it. We use it for our IUIs, but not for our IVF. So yeah, double trigger is better than single trigger. You could hyperstimulate, so just be careful. But aside from that, you should be okay. Instagram questions.
There's one. What do you recommend for the 41-year-old with prolactin, 60 normal menstrual cycle?
41-year-old with hyperprolactinemia? If you have hyperprolactinemia, it needs to be treated. So Dostinex is the best agent.
Do you recommend an amino in pregnancies with PGT euploid embryo? I had PGT done for my balanced translocation.
Yeah, you meant an amnio, not an amino. An amnio should not be done for sure if you have already PGT tested your embryos. You could maybe argue you want to confirm with an NIPT, but I wouldn't. I mean, you're 99 point something percent safe, so I wouldn't worry about it. Definitely not an amnio. That carries a miscarriage risk. That doesn't make any sense for anyone.
What happens if you make embryos but then find out you need a surrogate? But
They asked us that one. Yeah.
What are the risks of vaginal birth after 3 C-sections?
What? No. That's just a hard no. No one in their right mind would do that. Your risk is that your uterus will tear open and the baby will almost for sure die, and you could as well. You cannot try a vaginal delivery after 3 C-sections. That would be maniacal. Yeah, do not do that, please, I beg you. It's totally unnecessary and unsafe.
Would you suspect endometriosis if you get 2 to 4 cysts a year under 3 centimeters?
No. So cysts have nothing to do with endometriosis unless it's a cyst of endometriosis, and those ones don't go away. They don't come and go. They come and they just get bigger and badder. So someone who gets cysts routinely or regularly, it has nothing to do with endometriosis at all.
What are the most likely causes of failed fertilization after ICSI? I expected about 75% of mature eggs to fertilize, but only 50% fertilized. 12 retrieved, 10 mature, 5 fertilized, 2 blasts, MFI, 2M sperm, 42% motile.
So probably the sperm quality, because you've got male factor infertility. So if there's a lot of sperm DNA fragmentation, it's been shown to decrease fertilization. If the sperm quality is very poor, if your lab is not great at finding the good sperm, that has a lot to do with it. So most likely that's related to the sperm quality or the quality of the lab that you're working with.
One of your cars fell off the wall. Oh
no. As a matter of fact, 2 of my cars fell off the wall. The Lambo, the blue Lambo, oh God, it just stuck to the Porsche. The blue Lambo fell while I was away on holiday. I guess it missed me. The Porsche fell before I went on holidays. This is a 918 Spider. This is a Huracan Performante for those of you that like cars. So this thing was like cemented to the wall. So I actually have no idea how it fell off, but I will take care of it shortly. This one had tape, and the tape is no longer sticky. It's like a Velcro tape, so that's got to be changed.
Clinic wants me to stop progesterone at 10 weeks. Should I continue until 12 weeks?
10 or 12 makes no difference. We actually keep our patients on progesterone until 36 because you are a higher risk population. Your risks of preterm labor are higher, so we want to prevent that, and progesterone does. But most centers stop at 6. Some centers stop at 8, 10, 12. After 6, it doesn't make a difference unless you're going to stay on it for the whole time. So I wouldn't worry about that.
How many days before an egg retrieval should my husband be saving up his sample?
2 to 3.
Do you ever do 2-day or 3-day embryo transfers, or is it best to push for a 5-day blast?
No, there are some circumstances where a day 2 or a day 3 are reasonable. So if you failed multiple day 5s, you could try not a day 2, but a day 3. If you are doing a natural cycle and there's only one embryo, you could do a day 3. So there are instances where it makes sense. It depends on the patient and the circumstances. So we do them, just not frequently.
Interesting question for you.
Okay.
What causes embryos to not survive a thaw? Just did an FET and was told my 5AA embryo did not survive the thaw.
Nobody knows. Great question. Could be the embryo's energy efficiency, could be the way that they froze it, could be what happened to it. You got to remember, when they are freezing the embryo, they're actually dehydrating the inside of the embryo and replacing it with something that is safe to freeze. And the whole key to that process is to not allow crystals of ice to form inside the embryo, because ice crystals are sharp and they'll damage the organelles. So if you even had one little crystal form by accident, which you have no control over, obviously, it can kill the embryo. So it could be the freezing process, it could be the thawing process, it could be the embryo. We don't know what prevents them from surviving. Great question, though. No one's ever asked us that.
To me, I learned something. Hi, Dr. V. So excited for our first appointment with you next month.
Oh, great.
When I ovulate, I only have ovulation pain on my left side.
Okay.
I had a large cyst on my left side ovary that ruptured. Is this a concern? Thank you.
You may have some damage on that ovary and scarring, and if you do, that might be why it hurts. Could be endo as well. That can also cause pain. So any of those things are possibilities. There's no way to know till we see you do your ultrasound, sometimes even do surgery. Usually if you had a ruptured cyst, that's definitely not an endometrioma. So there isn't necessarily a connection, but a lot of times women who get pain on one side will have endo there.
Can a lot of scarring from a burst
Appendicitis, yep.
appendicitis act like endometriosis in terms of blood flow to the ovaries?
Endo doesn't alter the blood flow to your ovaries, so I'm not sure what you're asking. Endo and appendicitis would alter your fertility by causing damage to your fallopian tubes or scarring around the ovary, which can then cause problems with the egg actually being picked up by the fallopian tube. In the case of endo, it also impacts your immune function, in which case that's an additional thing that can happen that causes problems with fertility. Burst appendix after the infection has settled down would not cause prolonged immune disruption or alteration. So that's something that's specific to endo. But the majority of the problem from both of those is structural damage if it's bad enough.
Is there a Canadian place to order an auto injector for PIO shots?
Wow. I didn't know there was an auto injector for PIO shots. Why would you need one? You basically turn around, kind of flex your butt and go, psh, you don't need anybody to do it for you unless you're terrified of needles, in which case a partner or a friend should be able to do it. So that would be my suggestion. I'm not aware of anywhere that has auto injectors, but to be honest, I've never even heard of one before. So we could look it up. You guys could ask Kinga at Twin Oaks Pharmacy. She'll tell you.
I received a Lupron injection to prepare for FET, and then the FET was canceled. How long would the Lupron stay in my system, and what effects would it have, and for how long?
Depends on which one you took. If you took 3.75, it's in your system for about a month, and you won't feel any effects other than maybe some hot flashes. There's no long-term side effects from it usually. If you took a 3-month version, you will go into menopause. So hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, decreased sex drive. You can mitigate those by taking birth control pill or hormone replacement.
Is using Benadryl with dexamethasone safe in FET? Would you recommend using both or just Dexa?
You can use both. They work by different mechanisms, so there's nothing wrong with that. We got to call it quits soon. It's 5 more minutes. It's
you don't
9.
need 5 more minutes.
We're almost done?
Yeah.
Okay,
But
rapid fire.
So again, the minute you say, that's all of them. Then.
All right.
Okay. During embryo development, we have 100% fertilization and great development until day 3. After day 3, we see a drop off. Can this indicate a sperm issue versus an egg quality issue?
So we have this debate eternally. Nobody knows for sure, but I would definitely say that could be a egg quality issue. It can be a sperm quality issue, but initially it can be more the sperm, and then later it's more the egg. Although that rages between different embryologists. I've literally had embryologists argue that exact point. So it could be either one, but usually division past day 3 is going to have more to do with the embryo than the sperm.
It's my intent, by the way. I don't know if you know.
I do. That's why I said 5 more minutes.
Yeah, I was all in there. We have switched to a new doctor and will be preparing for an FET.
Okay.
Would it be worthwhile to repeat hysteroscopy? It has been over a year since our last.
No, not. So hysteroscopy is usually unnecessary. We don't do hysteroscopy unless we find something wrong on a saline infusion sonohistogram, which you should do.
She mentions
If
that
it's been used.
last only found mild endo and a small polyp.
So you can't find endo on a hysteroscopy. That requires laparoscopy. So I'm not sure what they saw, but that requires extensive discussion. A small polyp you should be able to see on a saline infusion sonohistogram, so do that and save yourself a surgery.
What size follicle will likely contain a mature egg? What size do you look for before triggering?
So if we're doing IVF, anything above 16 is considered a chance of mature. We're aiming really for around 18, so 17, 18, 19, sometimes 20. 20 starting to get a little long in the tooth. If we're doing IUI, you want it between 19 to 21. So it depends on what we're doing. We have had patients with mature eggs at just 15, so we do have to be careful.
I'm in Mississauga. What can I do as your place is too far and I would love to be your client? If you can direct me or tell me what to do.
So no one is too far. We have patients from all over the world, and we would be happy to take care of you from Mississauga. I got lots of patients in Mississauga. So all you have to do is set this up by talking to your doctor, your family doc. Have them refer you to myself, Dr. Victory, at Victory Reproductive Care. The fax number is 519-944-6406. 519-944-6406, or you can just email info@drvictory.com. That's drvictory.com, and set up a consult with me. And then we can get all your testing done wherever you are. I do work in a couple of clinics in Toronto as well, and have good friends in Toronto that can do testing for us. So that's not an issue, and we can get you treated wherever you want to be treated. So whether you want to stay in the Toronto area or you want to come to us here in Windsor, we can provide you essentially almost the same level of care anywhere we go. Done?
5 comments all over the place saying thank you so much.
Oh,
for
no
all
problem.
This is amazing.
Thank you guys. We will be back again next week. Hopefully there will be something wild and wonderful to talk about. So we'll see you again next week. Stay safe, get vaccinated if you haven't already, and we'll see you again soon.